Hi there, my name's Dr. Nick McQuarner. I'm a consultant paediatrician at Sangwell and West Birmingham Hospitals, where I run the paediatric allergy service across site. Thank you to Nestlé for asking me to talk today about a symptom-based score for cow's milk protein allergy, the so-called COMISS. These are my declarations of interest. I've received honoraria from Nestlé for delivering educational sessions and also received sponsorship to attend educational conferences. So this was an article I read when I first started my consultant allergy job in 2007, which said allergy cure just 3 years away. Obviously, I was slightly concerned that I'd taken the wrong specialty and that I'd be out of a job. But obviously, we know that's not correct. Obviously, this article was released when immunotherapy for hay fever became more prominent after the studies that were done. But we know obviously that this isn't the case, and there is a changing pattern of allergy with increasing incidence and prevalence, persistence into school age and even into later stages, and there's also an increasing rate of hospitalizations. And we know that allergies become a lot more apparent in the media as well, and more forefront in people's minds. And that's partly due to the number of deaths that have recently been reported in the media, including of all these children who've either died at school or during a takeout meal. And of course, recently there was Natasha with her reaction to sesame, and obviously Owen who reacted to milk in a burger. Again, both of these related to foods where the labelling wasn't as accurate as it should be. So I think allergy is very much in the forefront of people's minds at the moment. So if we look at anaphylaxis rates, we know that there have been a number of databases which are being reviewed to determine hospital admissions and fatalities caused by anaphylaxis. And if we look at the results of these, we can see anaphylaxis has gone up over that time. Between 1995 to 2010, it went up almost 600%. If we look at what's causing those reactions, you can see in children at the lower end of the graph, it is foods. And that's why it's particularly important for us in paediatric practice to understand this better. Obviously, you can see in the older age groups, it's generally iatrogenic related to drugs. So which food causes problems? So the pie chart on your left shows children under 16 years old. And as you can see there, milk is a big determinant of reactions, as are nuts. So because of the significant problem with recognition of allergy in children, there is a NICE guideline which was published in 2011. This was based in primary care and for primary care, and indeed an article showed that allergy was the third most common referral to paediatric care from primary care. The first two being gastro and dermatology, which have a huge overlap with allergy anyway, suggesting that allergy may be one of the most common reasons primary care refers to secondary care services. If we look at cow's milk allergy in primary care, we know that IgE is generally easy to diagnose. Non-IgE mediated symptoms are a lot more non-specific and therefore much harder. So this was a review in 2008 of 1,000 infants with cow's milk protein allergy. They followed them through the diagnostic journey, and 60% of the cohort had either gastrointestinal or skin symptoms. As you can see, the mean age to present at the GP was 3 months. Time to be put on a diet took longer, 2.2 months. Time to symptom resolution took another 3 months. And the diagnostic time from that presentation was another 3.6 months. So it's quite a prolonged journey there. There was an average of 18.2 visits to a GP a 12-month period. And you can see about 4 GP visits before an appropriate formula was started. So any strategy to reduce the time to treatment should potentially reduce the burden on health services, release resources, but most importantly, improve the quality of life of the patient, as we shall see. So if we just think about IgE-mediated allergy, most people would recognize this quite easily. It's a multi-system reaction, and obviously we know that mild reactions are more like lip swelling, eye swelling, and hives, whereas severe reactions are tongue swelling, difficulty, wheezing, hypotension and pallor, and obviously these can be quite severe and can result in death. So that would be anaphylaxis. Non-IgE mediated symptoms are very different. And transcend a number of, again, organ systems. We can see that on the right-hand side here, where if we look at the skin, we have problems with eczema. And if we look at the gastrointestinal symptom, there's a number of features there, which is a very common presenting complaint to GPs, reflux, constipation, loose stools, tiredness. So it's trying to work out when are these symptoms related to a standard pathology and when they may be related to cow's milk protein allergy. If we look at some of those symptoms in a little bit more detail, for example, reflux, we know that reflux either shouldn't cause any distress to the infant or will respond to treatment if needed. So symptoms that are severe, particularly with back arching, the so-called Sandifer syndrome, or the symptoms that do not respond to normal anti-reflux treatment, we should be thinking about cow's milk protein allergy as a potential trigger or exacerbating factor. Irritability and colic. We know that children have colic. It's usually an evening problem. They cry continuously and then settle down a bit later on in the night. So a child who's crying all the time, who seems distressed all the time, again, we need to think about, could this be cow's milk protein allergy causing that distress? Eczema that begins early on in life and that is severe and resistant to treatment. Again, we should be thinking, could these factors be leading us to think of a cow's milk protein allergy as a potential exacerbating factor? Loose stools that begin with the onset of trialling a cow's milk formula, for example, again may suggest a cow's milk protein allergy as the cause. Constipation, we know that standard constipation is such that the child will squeeze a very hard strain and they produce a hard stool. A child with constipation that may be related to cow's milk protein allergy will strain hard but produce a soft stool because it is mainly a dysmotility issue that's causing the constipation. And obviously we know that there is a subgroup of babies who pass fresh red blood in the stool and are otherwise systemically very, very well. And again, if this coincides with the introduction of a cow's milk formula, one needs to consider whether this is a proctocolitis caused by cow's milk and whether this needs to be excluded. Obviously, though, this is very difficult in practice because the knowledge around this area is not as great as we would expect. If we look at the incidence of cow's milk protein allergy, this is the Europreval cohort looking at 9 countries, and there were about 12,000 children with 9,000 followed to 2 years old. Cow's milk protein was suspected in 358 infants and confirmed in 55. The incidence rate was about 0.54% overall, but as you can see, there's quite a wide range of variance throughout the countries themselves. There is the UK, which has one of the highest incidence of cow's milk protein allergy at just over 1%. And you can see that non-IG cow's milk protein allergy actually contributes a vast proportion of that incidence. So it is by far the most common type of milk allergy that will be seen in primary care. And indeed, this is probably an underestimate because not all the clinical sort of symptom profiles were reviewed in this cohort. Getting the diagnosis right is really important because the impact is huge. It takes 39% longer to shop. It's significantly more expensive to buy the free-from foods. The quality of life scores are worse than those in children with diabetes because of that risk of fatal reaction that is always there. And there's a risk of compromised nutrition, either if you get the diagnosis right and there's multiple food restrictions, or indeed if people are avoiding multiple foods incorrectly, which again can lead to problems. Certainly we've seen vitamin D deficiencies and iron deficiencies in our paediatric allergy clinic because of inappropriate restrictions. So the diagnosis of IgE-mediated allergy is a lot more straightforward. We have specific IgEs and skin tests, and we know that these in combination with a very thorough and clear history will give us the likelihood or probability that there is a true IgE-mediated allergy and an appropriate management plan can be made. Non-IgE is much more difficult. We have to take the history, and based on that history we have to consider whether a targeted elimination diet will be useful. What we're expecting is to see a resolution of symptoms over that time, and then a recurrence of symptoms on the reintroduction of those foods. There's no real data on how long elimination should be tried, but most recommend 4 to 6 weeks. So a 4 to 6 week period of exclusion, where we should see an improvement in the symptoms we think are caused by the cow's milk protein allergy, and then 4 to 6 weeks of a reintroduction, where we should see a worsening of those symptoms. The management options, of course, for both are exactly the same, which is avoidance of the food. I think it's important to remember when we talk about cow's milk protein allergy that the gold standard nutrition for this is breast milk. All current guidelines support breast milk as a first-line choice for both the prevention and dietary management of the allergy. We should aim to follow the World Health Organization guidelines and make sure we sort of promote 6 months of exclusive breastfeeding. So we do need to support mother to breastfeed, to support her to avoid cow's milk protein if appropriate, and this is not really needed in most cases. We need to ensure mum has the right an adequate calcium and vitamin D intake, and we know that there are a small group of children where the mother is unable to or cannot breastfeed, and in those children we have to decide on a hypoallergenic formula, and then we consider which one will be most appropriate. So really, breastfeeding should only be stopped at the time or age of infant as chosen by the mother. If the baby is symptomatic on breast milk and we are unable to get an improvement or compliance on a maternal dairy exclusion, as I've mentioned already, this is very rare. And if the infant is not thriving, but rather than stop breastfeeding in this scenario, we will be suggesting supplementary formula. So if we look at sort of diagnosis and management of milk allergy, there are a number of guidelines out there, as we can see. Unfortunately, there's much out there, but very little is actually read. So if we look at these, there should actually be enough information to diagnose and manage children with cow's milk protein allergy. So let's think about the diagnostic journey of a child and family with cow's milk protein allergy. We have some surveys from June 2014 where data was collected both from families, so 300 parents of children with cow's milk protein allergy and 400 GPs. So this is sort of data will be split into parents and GPs. From a parent's aspect, 49% of cases were diagnosed in the first 6 months of life. To reach a diagnosis took an average of 10 weeks and a median of 4 visits. And you'll remember from the earlier slide I showed, again, that was the number of visits it took. So nothing much has changed since 2008. Prior to seeking advice, at least half had tried a self-directed elimination diet, and 8% had used a high street test to aid diagnosis. What was clear from the information we had is that there is a significant burden on the family. Symptoms reported in at least half of the parents were poor sleeping, persistent crying and abdominal pain in the infant. And this had an adverse impact on the parent's life, which included a feeling of exhaustion, stress and anxiety. Fathers often delayed going back to work, and they didn't enjoy time as a family themselves. Now, they also felt that they were overreacting when taken to the GP and they weren't taken seriously. So again, very sort of a difficult journey if we look at how that sort of transpires. If we look at what the GP said, to reach a diagnosis took a median of 8 weeks, so a slight discrepancy there, but all GPs did agree it should take only 4 weeks. They did find it difficult to distinguish symptoms, and in fact 4% listed anaphylaxis as a non-IgE mediated reaction. Most were not familiar with the guidelines, so only 13% were very familiar with the NICE guidelines that we discussed a bit earlier, but only 6% followed it. And 30% felt parents could help if they completed a symptom or food diary. And they also felt that it would be useful to have more education on cow's milk protein allergy, but also tools to make the diagnosis easier for them. These are the results of 2 surveys which were taken in 2012 and 2017. So again, if we're looking at that time period, not much seems to have improved overall. It still takes a median of 5 visits to get to the GP, and 15% took even longer. So there is an improved confidence in healthcare professionals in diagnosing cow's milk protein allergy, as you can see there, and less parents felt that their concerns were disregarded when being seen. Again, there was an ongoing impact on the quality of life, and many felt that they had to tell the GP themselves that they felt that the symptoms of the child were related to a cow's milk protein allergy after having done research on the internet. And this is despite the IMAP guideline being present at this time, which remember was a guideline seeking to improve the diagnosis and management of children with non-IG mediated allergy in primary care. So things still seem to remain fairly static from the point of view of recognition and understanding. So this is where we come to this symptom-based score to improve awareness of symptoms that may be related to a cow's milk protein allergy. So there was a workshop in Brussels in 2014 where 18 different experts attended from 14 different hospital sites. Their aim was to develop a tool which would help to raise awareness that the symptoms the child was presenting with may be related to cow's milk protein allergy, so specifically a non-IG cow's milk protein allergy. It wasn't meant to be a diagnostic tool, but an awareness tool that this child may benefit from an elimination diet to see if these symptoms can be resolved. So this is where the COMISS came from, which stands for Cow's Milk Related Symptom Score for Young Children. And the idea was to find a set of symptoms which, when combined, may lead to that suspicion occurring. So we know that a majority of children have one or more severe symptoms, and again, one or more organ systems affected, particularly the gastrointestinal or skin. So the symptoms they sort of agreed on were as noted: general discomfort, particularly crying and persistent crying; gastrointestinal symptoms, including reflux, regurgitation and loose stools in the form of diarrhea; respiratory symptoms, although bearing in mind that respiratory symptoms can be caused by a number of other factors such as respiratory viral illnesses; and dermatological symptoms, such as we've discussed, such as eczema. So these together led to a scoring system which we'll now discuss. They put this together into a scoring system that's noted there. So crying, obviously the more you cry, the higher you score. From a regurgitation aspect, they used a score that was developed in a paper looking at the sort of impact of anti-reflux treatment, which is what the only sort of scoring system they could sort of find that would be useful there. From a stools aspect, it was a Bristol stool chart, which is very easy to use and commonly used, and therefore there's familiarity with it. From a dermatological aspect, it was a SCORAD score, is sort of the most recognized tool. And there's a PO SCORAD score, which is a parent-orientated SCORAD scoring. This still needs somebody to go through the body chart with the parent to decide the score. Now, obviously, in the context of a scoring system that we want parents and GPs to use, this will not be sort of appropriate. So instead, they amended it slightly. So they use the Burns percentages to work out a SCORAD score. So it's really a modified SCORAD system. And then you can see there's respiratory symptoms there at the bottom. And we recognize that respiratory symptoms in children can be caused by many things other than an allergy, including viral illnesses. So therefore the scoring there is slightly different. So if you look, the first 4 symptoms are scored out of 6, whereas respiratory symptoms are scored only out of 3. The scores ranged from 0 to 33. Each symptom having a maximal score of 6, except the respiratory, which we've already said is 3 because of that crossover. There's an arbitrary cutoff of more than or equal to 12 to sort of pick up a child who may be at risk of having cow's milk protein allergy as a cause of their symptoms. So if we look at sort of why that arbitrary cutoff was sort of decided on, the score of 12 looks at the presence of at least 2 severe symptoms, and a score of more than 12 looks at least 3 symptoms in 2 different organ systems. And as we spoke about earlier, often with cow's milk protein allergy, it's not one organ that is affected, it's a number. And if the score reduced by 3 or more, then this was deemed as clinically significant. They then put this into a form as noted here, where actually it's much easier to see the layout, score, and add the total score up. And at the bottom you can see is how you'd interpret it. So this was an initial pilot study looking at the COMISS tool to see how it would work. There were 116 infants in this study, which had a score of more than or equal to 12. They had a 1-month elimination diet, and then the plan was for an open challenge. Unfortunately, almost a third of patients refused a challenge because of dramatic improvement in their children's symptoms when they went cow's milk free. So in the remaining children, their mean score at inclusion was about 14, and there was a clinically meaningful decrease in the score in 94% of children, as noted here. When the open challenge was done, in those whose score had dropped to less than 6 from what it was originally, there was an 80% positive challenge, showing that a response taking your score from wherever you were down to less than 6 will be more likely to represent symptoms suggested by cow's milk protein allergy. So that was really a proof of concept study. Then there was this pooled analysis looking at 3 different studies, one of which was a pilot study we've just looked at, but another 2 studies which were actually looking at the impact of different hydrosylates on cow's milk related symptoms. They use a COMISS score in this, and they did a regression analysis 1 month after an exclusion period. They used a receiver operating curve to determine an area under the curve. And you'll remember an area under the curve of 0.5 suggests random prediction. An area under the curve of 1 suggests absolute perfect prediction. So if we look at the results here, infants having a low COMISS 1 month after an elimination diet have a significant risk of having a positive challenge test. Again, showing that that dramatic decrease in the score suggests that your symptoms may well be related to a cow's milk protein allergy. The area under the curve wasn't 1, it was 0.88, but again suggesting there is some utility in prediction here. And again, the cutoff seemed to be correct at more than or equal to 12. The question I suppose would be here then, what is a score in a healthy infant? Because none of the infants after completing their exclusion diet had a score of 0. So that's what the next study was about. So in this study, it was across 4 countries, Belgium, Italy, Poland and Spain, and general paediatrician determined the COMISS in healthy infants during a routine visit, and these children were up to 6 months old. What they found, so what we've had was complete data from 400 infants, and 50% were breastfed, 36% were formula fed, the others were mixed fed. The median COMISS in a healthy infant was 3, with the 95th percentile being around 9. This is a range of COMISS scores in healthy infants, as can be seen, which range all the way up to 12 really. And this is a changing score over age, and this one that significantly changed. So the blue here is a score of 0, was crying. You can see that crying reduces as a child gets older, as do a number of the other symptoms. But the important thing here again is recognizing that a healthy child would have a score of around 3. And again, what they reinforced here, well, this was not a diagnostic tool, but an awareness tool that may help decide which children will benefit from an elimination diet. So what about a direct comparison? So this was looking at children in a pediatric gastroenterology clinic. What their aim was to assess the accuracy of COMISS in response to a cow's milk free diet and determine the specificity and sensitivity of COMISS in these responders. So they looked at children under 12 months old, and they had 47 infants on an elimination diet here. And these children were placed on this due to persisting unexplained gastrointestinal symptoms. COMISS was done on recruitment and whilst on the exclusion diet, and 83% responded to the diet. The score was higher in cases, around 8, versus the healthy controls, and those 94 controls had a median score of 3, which is what we'd already seen a healthy infant would have. Oral challenges were positive, and a ROC curve in this case identified 9 as the best cutoff value. So slightly different to the 12 that was seen. But again, this was small numbers and needs a bigger study to determine how useful it would be. But from their point of view, they also felt that this would be a useful tool potentially to monitor response to treatment. So here you can see that the score was higher in those who responded to those who did not respond. And there was a drop of at least 6 between the median after the elimination diet. Again, suggesting that that seems to be the right kind of cutoff. So obviously, can parents do the scoring? Because that would make life easier. Absolutely they can. In this study here, 148 infants, the parent and the paediatrician completed the COMISS tool, and they were pretty much the same, and there was very little inter-rater variability as well. So again, they can be recorded. The COMISS could be recorded at home by the parent and brought in. It could be recorded in the waiting room whilst they're waiting to see the clinician, and the results will be just as valid. So what about the relevance in different settings? So there are some now studies and emerging data showing the use of COMISS in different populations. In this Turkish study, there was 168 children, and they felt that COMISS was a valuable tool to evaluate cow's milk protein allergy in the primary care setting. And the presence of multiple symptoms, especially skin involvement, helped to recognise infants with potential cow's milk protein allergy. This was a study in Indian children. There were 83 in this study. And again, their conclusion was that COMISS can help predict cow's milk protein allergy in children aged less than 2 years old. Again, in the primary care setting, but they felt that further larger studies were needed to evaluate the use further. This study was in European children from Belgium, the Czech Republic, Germany, and the United Kingdom. This was a larger study with 268 infants, and what they found that again the median COMISS score at inclusion was 11, with a range of 8 to 14. After 3 weeks of intervention, which was the exclusion diet, the score had dropped down to 4 in a median number, but ranged from 2 to 6. And you can see that the scores after 3 weeks were in line with those considered normal in healthy infants. So again, the conclusions here was that COMISS is a useful tool to increase the awareness of cow's milk protein allergy in the real life setting, although there were differences noted between the 4 countries, particularly that again there was a delay compared to other countries in the seeking advice and recognition of the potential cow's milk protein allergy contributing to the symptoms of parents. The final study here is from Chinese children. This was a smaller study with only 38 infants. But again, they felt that the tool was simple and, most importantly, easy to operate to screen for cow's milk protein allergy. They felt there may be a risk of underdiagnosis if a COMISS score of more or equal to 12 was used, and that this needed further evaluation. But again, we can see that there are a number of settings now suggesting that the COMISS tool may well be quite useful, but more studies are obviously needed. So what does this mean for you? Well, again, I think it's important to reiterate this is not a diagnostic tool, but an awareness tool. And it's probably best to be used in the primary care setting at the moment to identify children who may have symptoms associated with cow's milk protein allergy. It could also be used by allied health professionals, including dietitians and health visitors, to maybe do the score before referring to a GP for consideration of an elimination diet. And I think the key thing is it will help identify a group of patients who are most likely to benefit from an elimination diet, and most importantly, avoid unnecessary elimination diets. If I think about our own trust, we have a paediatric allergy service seeing approximately 3,000 patients per year. There's a dietitian and nurse-led non-IG mediated clinic, and into this, GP and health visitor referrals are sort of reviewed and assessed. So we thought we'd see how the COMISS tool worked in this clinic. So this is just as one case. So this is Tom, obviously name has been changed, who's 4.5 months old. There's a family history of atopy, and he was breastfed initially. He was converted to formula at 3 months old, and became quite sort of difficult to feed. He didn't feed very well. He was screaming, miserable, back arching. He had started to develop loose stools. The GP tried some anti-reflux treatment, but really the symptoms didn't improve. There was a slight improvement, but not enough. And it was still causing quite a lot of distress to him and obviously the family as well. His weight had fallen slightly from the 25th to the 9th centile. So he was referred by the health visitor to the clinic. So his COMISS scoring was done, as noted there. And obviously he had quite severe symptoms in one organ system. As you can see, the score came up to 13, and the symptoms were felt to be caused by cow's milk protein allergy because of that. He was commenced on a hypoallergenic formula, and the plan was to review in 4 weeks' time. So he was reviewed 4 weeks later, so he's now 5.5 months old, and as you can see, he's thriving and appears much better. The loose stool settled over 5 days, and the reflux symptoms are now controlled with medication. He didn't come off the medication, but they're much better controlled. So the dietitian was to continue ongoing follow-up, to consider reintroduction of milk, and give ongoing weaning advice. And as you can see from this repeat scoring we did there, that the score had dropped down to 4, which again would be in the realm of a healthy infant. So that was a really good outcome and a really nice demonstration of how the COMISS tool can be used in a healthcare setting. So what about our changes to working with the COVID pandemic? We know that many of our allergy services at the moment have recommendations that telephone or virtual consultations should replace face-to-face consultations, and day ward appointments are either reduced or stopped, and certainly that's what we've seen with our allergy service. Telephone consultations reduce exposure of patients and staff to potentially infected patients and prevent the COVID-19 spreading. So it's becoming really central to delivering healthcare in general, and indeed that is reflected in our allergy services. And I don't think there's going to be a quick fix to this. I think we're looking at another at least 6 to 9 months of these restrictions being in place to a greater or lesser extent. So we need to be thinking about utilizing new technology, and this is a tool that may help with that, called the Smiles Back app. It was developed with allergy experts and primary care physicians, so that sort of trying to sort of help with that crossover between primary and secondary care. It can be used to complete a COMISS before an appointment, before the child sees you, and the key information is recorded by the parent and summarised into a single page report, which can then be utilised to fill in the COMISS scoring. Again, it's important to recognise it's not a diagnostic tool, but helps you decide whether symptoms may be caused by cow's milk protein allergy. So basically what would happen is that the parent would download the app to their phone, and then the parent will fill in a diary of the symptoms that their child is experiencing on a regular basis. This can then be put into a report which can be emailed to yourself or your administration team. The information in that single report can then be used to do a COMISS score, and if that COMISS score is obviously more or equal to 12, you may decide if the child is not being breastfed that a period of exclusion is required, and start that elimination diet before the child comes to see you. Obviously, once the elimination diet is complete after 4 weeks, you repeat the COMISS scoring to see if there's been a drop, which again suggests that the symptoms may be caused by cow's milk protein allergy. So a very nice tool, and I know certainly it's been used in a number of allergy centres around the UK during this unprecedented time where patients' face-to-face appointments have been reduced. So, in summary, what we've discussed today is that non-IgE mediated allergy to cow's milk is often difficult to diagnose compared to IgE mediated allergy, as there is quite a wide range of symptoms and they're often non-specific. COMISS is a symptom-based score that could help to identify children who may benefit from a trial of elimination diet. It's not a diagnostic tool and does not replace challenges. It can be used by clinicians, allied healthcare professionals, and even parents as an aid to sort of identifying those children who may benefit from that elimination. Evidence for use is slowly emerging and further studies are planned. At the moment, in the current COVID-19 pandemic, there is a digital platform which facilitates its use within paediatric allergy services and may be worth considering for your patients. Thanks for listening.
Good evening, everybody, and thank you very much, Nick McCartney, for an excellent presentation. We are now going on to the live Q&A. So if anybody has any questions they want answering, please make sure that you type them in and ask away. We have had a question in terms of actually will slides be available, and they will be. We can reassure you that they'll be sent out with the follow-up email after obviously today's session. I've just got another question for you here, Nick. The tool looks great. I have two questions. Firstly, is it branded? And secondly, are there any information governance issues around its use? Is the patient data safe?
So I suppose it depends on how you use it. If I answer the second question, so how we use it is obviously in the clinic we will put the information into the tool and then put it into the notes, so it's scanned into the notes, and obviously the physical, if it's scanned in, we destroy the hard copy. So it shouldn't really go anywhere else. And I'm assuming if you use it if the GPs use it in their practice, it will be a very similar process. It will form part of the patient notes. So really the data should be in where it should be. Is it branded? So at the moment, I think my understanding is it has got Nestlé Health Science at the bottom of the form. I don't know, Charlotte, if you wanted to clarify that, but I think that's a very good point. And I suppose some people may be uncomfortable using it with a brand on it. So I'm not sure, Charlotte, if there's any plans to have it without the branding at the bottom. Could you clarify that at all?
Yeah, unfortunately, it is branded at the bottom. It's a tricky one because we do have to kind of have it branded to be open and honest that it is our tool. So it's a tricky situation, but yeah, unfortunately, it is branded. But it is very small and it is the bottom. But it's just so people are aware that it is our tool as well. And I suppose you're right. You've got to show that it is, sort of developed by a team from a formula milk company, but obviously what the development of it was not sort of pushed by the company itself. It was a number of allergists, paediatricians, gastroenterologists who came together and put the tool together. Great, thank you. And sorry, she just written in again and said, sorry, the question was around the app. Is the app branded and is this information safe? And Nick, you probably won't know this. In terms of the app, it's not branded, but we do have to say that it's Nestlé Health Science when they download it, again, for the same reasons in the term that we have to be open and honest, that it's a Nestlé Health Science branded app, Nestlé Health Science app. So although the actual app itself it is on when they go to downloads, and all the information is kind of done within data protection as well. And they have the notifications that will come up as you would do normally if anything's kind of going to any third parties or anything. Okay. And the next question, how do you manage an infant on breastfeeding with bloody stools?
Oh, okay. So an infant who's breastfed with bloody stools, I mean, it's not, so that's obviously a proctocolitis, so we know it's a very small number of kids who are breastfed do get this non-IgE type symptom. So what I normally do is ask mum to exclude milk from her own diet. Obviously, as we've said already, supplementing her with appropriate calcium and vitamin D. And usually you see a change within 48 to 72 hours if it's related to that.
Thank you for that one, Nick. Another question. Do you think that the COMISS tool should be incorporated into the GP system to aid diagnosis and avoid any delays in diagnosis?
Okay. So again, it's just that it's an awareness tool, not a diagnostic tool. So it doesn't diagnose non-IgE-mediated allergy. It sort of helps you decide whether the symptoms could be because of it. So I think you're right. Hopefully the data I showed confirms that it is still poorly understood, poorly recognised, and therefore there's a long path to diagnosis. Although there are some online tools out there, but they're quite complicated. So actually, yes, absolutely. I think putting this scoring system into a GP's daily to use would be useful. But having tried to do something similar with another NICE guideline and trying to incorporate it, it's a really arduous, hard process. And there seems to be, interestingly, quite an appetite to do it. Now, obviously, I think people have looked at the cost, and there is a cost associated with the delayed diagnosis. So I suppose it's just working with your local teams. I think it's not going to be something that's been rolled out nationally, but certainly working with your local GP teams and seeing if they can incorporate into their own local systems will be a good starting point, particularly if you know there's a problem locally and your services, as many are at the moment, quite overwhelmed with referrals because of the backlog.
Thank you, Nick. Thank you. And also, how can you see other clinicians, apart from GPs, using the COMISS tool?
Okay. So again, hopefully I sort of touched upon that in the talk. So obviously from our point of view, with our non-IG clinic, the dietitian or the nurse fills that in. We've also working, because I look after the whole child and health, women and child health group. I also am responsible for looking after the health visitors. And actually at the moment, what we're doing is trying to train up our health visitors to sort of understand the tool, understand how to use it, so the health visitor themselves can directly refer into our service rather than have to wait for the GP to then see the patient, consider the diagnosis and send it in. So that's a twofold benefit. One, it shortens the journey because the health visitor can refer directly after completing the tool. But secondly, it eases the burden on the GP because they won't have to keep seeing that patient because they're referred into the right service straight away. So really it's a resource issue for the GP, freeing it up and improving the pathway. Also, I suppose a bit like the gastroenterology clinic did in their study that I sort of presented there, you could use it in the allergy clinic itself to look at the response to an exclusion diet. So if you see a child who comes in as a secondary care referral with symptoms suggestive of non-IG mediated allergy, you might fill that in when you see them. You may then complete the scoring, put the elimination diet in, and then either you or indeed one of your team could ring up the patient 4 weeks later to do a symptom score and see if there's been a drop. Because if there has, that would suggest that the diagnosis is correct and that your symptoms did fit with that, and then you would just manage it that way. So it could again save some patients coming into the hospital, especially at this time of COVID. We're trying to reduce that. So we'll have the initial hospital appointment, get their scoring done, get the elimination diet, someone can ring them, check it's worked, and then they come back for a routine follow-up appointment at a later stage.
Thank you for that, Nick. And also, do we know the sensitivity and specificity? Oh my gosh, I can't say this word. Sensitivity and specificity of this tool. That's a real tongue twister.
Yeah. So I think the data from, I can't remember which study it was, said it was about 89% sensitive and roughly the same sort of amount specificity as well. So I can't remember the actual values, but it was in the 80s for both. And remember, it was just sort of, it gave that awareness and the area under the curve, remember, that I showed earlier, looking at the sort of predicative value of that tool in demonstrating the child will respond to an elimination diet was about 88. So remember, area under the curve of 1 suggests perfect prediction, and this was about 0.88, so fairly close to 1. So that sort of scoring plus the drop down to less than 6 would be a really good sort of indicator that the symptoms are likely to be due to a calcium protein allergy.
Thank you, Nick. And just going back to the question that was asked before, we've had a health visitor actually message in saying, not a question, but I am a health visitor, independent nurse prescriber, and we use the tool regularly to support our diagnosis and then prescribing. It is definitely a useful tool for us. So that's kind of good to know. That would hopefully answers that previous question about how you would use it in other specialities.
Yeah. That's great. Yes, and obviously that sort of fits with the work we're doing with the health visitors being able to refer in directly if needed. But again, remember, a lot of these non-IGEs, if you look at this sort of the IMAP guideline, which I highlighted there as well, the non-IGEs in theory can be managed completely in primary care and don't necessarily need to come into the secondary care services at all. So absolutely. So between health visitor and the GP, in theory, these children could be managed out in primary care.
Thank you. And I think we've got time for one last question, which is, with restricted face-to-face appointments at the moment, does this represent an ideal time to try the tool? And how accurate would the results be if conducted over the phone?
So I think, yes, absolutely will be the right time. I think that's why I sort of touched upon the app at the end. But again, over the telephone, it's absolutely fine. So, because remember, the patient can fill it in, and the patient's accuracy is as good as the paediatrician's accuracy when it's filled in. So actually asking the patient the questions and their answers will be just as good as if you ask them face to face. So yes, absolutely, it can be used over the phone, I think, and will give pretty much the same result as you expect to see face to face.
Brilliant. Thank you very much. Thank you for your time, Nick, and thank you very much for everybody for joining us today. And I think we can all thank Dr. McQuarner for an excellent presentation today.
No problem. Thanks very much.